It's really, really changed. And that's why we're live now, so that's why I mentioned about probiotics and such like just before. But that's something else I have to bring Katina up to speed with, philosophically and knowledge-wise.
What often happens when you introduce me to something new? It doesn't go well.
Initially, there's a denial process, but she absorbs it, and she good and questions it, which is good. And so the more she questions, the better, until she's comfortable with it. And we may get her to do a complete transformation to a different view of the world.
Very true.
Well, the underlying principle is even in a hospital setting, if there's no outbreaks or no microbes, bacteria, viruses of real concern, then you're best not to disinfect. You're best to leave a environmental microbiome of microbes on surfaces. So our usual bugs, pathogens, if you like, cannot get established. And there's really good evidence to show if you use a probiotic and detergent cleaner rather than a disinfectant, you can reduce hospital-acquired infections by about 50%, by about half.
Ben, is that a new study?
There's a number of studies. I first saw it about 15 years ago, the concept of it, and it makes very good sense. For instance, and I use the example, if you have a lawn with grass on it, and there's a little bit of broadleaf in it, and you want the broadleaf's increasing a bit, and you really want to get rid of it, the ideal is to have a broadleaf only spray that only kills broadleaf. But often that's not possible. We don't have sprays that only kill pathogens. So then the next thing to do is to use a broad herbicide, and that will clearly get rid of all the broadleaf in the lawn, but it gets rid of the grass. Then you have a problem. What grows back first? Is it the grass that grows back? And it's not. It's the weeds that grow back. So if you get in first and put a probiotic on that bare earth, then you stop the weeds growing back, if that makes sense. That's it in a nutshell anyway. And so that's probiotic hygiene. So you get rid of the pathogens, then it's the equivalent of putting yogurt all over the floor. And that's better because the other things can't get established.
I'll give you 2 hours to talk on that one. I think including the microbiome.
Yep. 2 hours on microbiome sort of comes into hygiene and cleaning and probiotics. Probiotic cleaning, completely different view of hygiene. But that's another. Yep.
All right, we're live now. Just quickly, hi guys. Okay, Senior, you know this guy comes every one of your sessions and he comes and asks questions. And we've got Shamiso right there. Shamiso Ndepiago. We missed you this morning. How do you say that, Ben?
Shishamiso, is it?
Ben, how do you say my last name?
Shivasa.
Ben, Chivasa.
Chivasa.
We fight every time when you introduce me. It's like, come on, dude, just. All right. So thank you so much, guys, for joining us. We're just here. If you've got questions for Ben, just feel free to shoot in. That's, he's our medical microbiology and scientist, and he's here to answer any questions on COVID-19, any other infection control related questions or infectious diseases or just anything at all to do with microbiology. He'll answer it as much as he can. And I've got Mark today. The reason being, Mark is going to be taking over most of these sessions. So that's why today I think I'm going to be a little bit on the backstage, won't I? I don't know. You guys, you can talk and introduce each other, whichever way you want to do it. Is that all right?
Of course. Greetings, Mark. Good to see you. Now that I've been here a couple of times, your first time. I understand you've got a number of skills, including retail, but also university, HR. So that's good to see. Good to have you on the show. And we've just met a few minutes ago, so that was really nice to see you. Thank you.
Yeah, thank you for welcoming me on the program. Yeah, my name is Mark Mazikana, originally from Zimbabwe, but I migrated to the United Kingdom. Yeah, I live in Manchester. For all those who are wondering where I live in the great city of Manchester. So yeah, I'm currently trying to upgrade myself into more professional grounds in my life. I'm currently in a professional ground, but I'm trying. I'll make it. With the support of Katina and Ben, I think I'll make it. I might even include you in my dissertation at university.
I know how that works.
Yeah. So it will be interesting, really. Because nowadays, if you do a dissertation, you can include videos, interviews, you can include anything, as long as it's genuine. Yeah. So yeah, watch the space. So yeah. So I'm here to learn. First of all, I'm here to learn, and also to give people what they like hearing. Like live sessions about education. So this is mostly about COVID-19. But Ben is very professional. He can extend the topic going outside the COVID era because he's got loads of knowledge in the health field. So yeah, so I'm happy to be here, really. So yeah, let's do it.
Awesome.
And
Thank you, Mark.
At the end of the day, I think it's all about personality.
Yeah.
And the more we can share personalities with good listeners, the better. And the more questions will come, and the more it'll flow amongst all of us, both on the show and indirectly on the show. So thank everyone for joining us. Thank you for joining us, Mark, and thank you for hosting us, Katina.
That's all right. I think what I'm gonna do is I'm gonna turn off my camera and I'm gonna mute myself, and I'll just let you guys. I'll flash the questions for you, but I'll just be in the backstage. Is that okay, Mark?
Yeah, no problem, man.
Yeah, because Mark, the good thing about Mark is that Ben, he's one of those guys that was, he's been there from the start. He was shooting some questions. I think on our first session, he was shooting a lot of questions. Him and Broch and Senior, I think they were there. So you know how this whole thing rolls. I'll be in the backstage. If you need me to kick in, I'll kick in. All right.
Yeah, no problem.
Anyway, don't mute yourself.
All right, thanks, guys.
Okay.
No, because I don't want to make any sounds. I'll be here. I can hear you and I can flash the questions in.
Okay.
Okay.
So Ben, do you want me to read the questions out to you, or?
I think, or else I can. When they're in English, I can anyway. You can read them out. You can read them out, Mark. That's fine. You read them out, and then there's a good challenging one for a start. Because a number of the listeners won't be able to see them. So thanks, Mark.
Yeah, like what Katina was doing in previously. So we'll just do that. There's a guy called Vic Valentine. He's got a question for you. In terms of evidence-based medicine, would you say that current vaccination protocols have room for personalisation? You can see that question. It's a more like a critical analysis. You can answer that, yeah.
That's a good question. One would have to say yes to a certain extent. For instance, there's no harm in vaccinating me twice for measles. If I've already been vaccinated and doing it again, sometimes it's cheaper just to vaccinate people en masse. So I may not remember if I've been vaccinated. We could do a test to see if I've got antibodies, or my parents may not remember if I'm a child. So we could do a test to see if we can detect antibodies. But sometimes it's easier just to go ahead and vaccinate everyone en masse. Then it may need to be personalized according to age. So when we're younger, we have the mumps, measles, rubella type vaccines. As say we were 30 or 40 years old, if we had not had those vaccines, there's a fairly good chance, possibly especially in Africa, that you would have been exposed to it anyway. So there's not so much need to give a mumps, measles rubella vaccination when you're, say, 60 years old, if you didn't have it before. But the personalized part of it, it's more important, say, when you're over 60, to consider having a vaccine, if it's available, for pneumonia, chest pneumonia against a bacteria called Streptococcus pneumoniae, and possibly, if it's available, against shingles as well. So at different ages and stages, we should be vaccinated. Now, I'm not sure if that's the complete response you're wanting to the question. Other things may depend on a risk-based behavior, depending on if we're traveling, what are the bugs in the region that you're traveling to that we need to be more careful of. And so that may be a type of personalization protocols too. So I hope that answers, Vic. That may or may not. Please get back and type in if you want further clarification on that. So, yes.
Yeah, so Vic, if you're watching, I think Ben is explained very well. So if you've got any further questions, just if you didn't clarify the way you want it, just type in your question and you'll find the answer. He's here, Ben. He's very knowledgeable. He's here. Yeah, so yeah, I think this guy, what he was talking about, I understand why he's asking that. Because when we're young, when you're growing up, you get these vaccines when you're very young to protect you from these diseases. In Africa, they call it immunization. It's done in certain stages in life. Like if you are 1 year, you get a certain jab. 2 years, you get a certain jab going, forward. And also, when I came into this country, they usually ask you, did you have this vaccine? Did you have that vaccine? And they want to, no matter how old you are, they insist for you to have them jabs. So I don't know, but it's the way they do it. They want you to have certain jabs. They'll say, oh, did you have this jab? Even if you had it and you don't have evidence that you had the jab, they'll insist that you have it to prevent you from whatever. So yeah, so I think that's where the guy was coming from.
Sure. He's followed up, which is great. So if you read out his follow-up question.
Okay. Oh, Vic is back again. He said, I asked because in terms of the COVID vaccine in Oxford trials, some people showed stronger responses than others to the dosing. Okay, I get it, yeah.
Okay, so that partially raises, thanks Vic for asking more, that partially raises not just for vaccines, but for the whole of medicine. Over the next 20 years or so, all of us are different. And so it may be, if you need nothing to do with vaccines, if you need a certain drug for a cancer or an antibiotic for an infection or something else, then yes, it would help. We don't know very much about it now, personalized medicine, to know if your particular genetic type, for instance, will respond or not to that particular, say, anti-cancer drug. Or, of course, the simpler one is if you've got an infection with a particular type, species of bacteria, if it's pre-tested, then we know if it's going to be resistant or susceptible to the antibiotic that would normally be used. So that part of it is personalized, and more in future we'll be able to tell at a reasonably cheap rate when you're born what are the most likely infections you're likely to encompass in your life. It's a bit scary on the one hand, but on the other, you can pre-look for them and track for them and hopefully take mitigating lifestyle choices. If you knew you're going to be a lot more predisposed to diabetes or high blood pressure, you'd change, or at least you'd have the opportunity to change your lifestyle to try and reduce that higher risk that you've got because of your genetic type. Coming to the COVID vaccine specifically in Oxford trials, yes, some people will respond better. In general, it's likely to be there are many different, I haven't re-looked up the COVID ones specifically for Oxford recently, but in the States, they're starting to warn on what I would say is the obvious and always has been. It's looking as though the over 65-year-olds may not be responding as well, which is just like influenza. and yet they're the people that need it most. It's over 65-year-olds that have an underlying illness that are most likely to die. Now, both those things, over 65, especially 70s and 80s, especially if you have diabetes or high blood pressure or respiratory pulmonary issues, you're more likely to die if you catch it. Still 90% will survive, but you're more likely to if you're 70, 80 or 90 years and have those underlying health conditions. But if the vaccine doesn't work so well for you, then it may work better for people under 60 who have a better immune system and are less likely, much less likely to die of COVID. The majority of people under 60 are going to survive COVID. It's a little bit hard, the difference, and I've mentioned on the show before, the difference between absolute numbers, 10, 20, 30, 40, 50 have died, maybe children, and percentage numbers. So in the United States at the moment, for instance, for every 100,000 deaths, that's a huge number, that's an absolute number, but every 100,000 is only, if I can use that expression, 0.03% of their population. 0.03% of the population, and most of those will be in the 70 and 80-year-olds with an underlying condition. So the advantage then, if I come back to the Oxford question, ideally you would give it to the over 60 and 70-year-olds, but if it doesn't work very well, then you need to try and vaccinate all the under 60-year-olds to develop a herd immunity in the general population, so it's less likely to get into the over 60-year-olds, if that makes sense. So there's some trade-offs there. For instance, and this is a slightly unusual one, if I use influenza vaccine as an example, there's good evidence. If we know that seasonal influenza vaccine, most people that die of it or with it, because they've got underlying conditions just like COVID, most people will be over 65. They're the vulnerable group. But the seasonal influenza vaccine is only about 20% effective. It only protects 20 out of 100 people who are over 65. For people under 65 who have better immune systems, they're much less likely to die of influenza because they have better immune systems, and it's 60 to 70% effective. So it protects 60 to 70%. Now, there have been some really good studies done in Japan and the United States. If the really vulnerable group, over 65-year-olds, even if they were not vaccinated and only under 16-year-olds were vaccinated, then the effect is we have a 60 to 70% efficacy for over 65-year-olds. And it's a bit topsy-turvy, even though they haven't been vaccinated. And in that case, the reason is children with influenza are the main shedders and spreaders of influenza throughout the community. It gets into a school, it rattles around the school, the children go home all over the community and spread it up to their parents and grandparents, and then they get it. So if we protect those ones, then we don't spread it to them. So I've given a reasonably long answer to that, I'm afraid, but I hope that makes sense on the personalized. Sometimes it's not straightforward. The most vulnerable, we can get better effect by vaccinating another group of people, even though they're less likely to die of it. So I hope that covers that, Vic.
Yeah,
rather long
I think you've explained it very well. I'll just crack on with the questions I've got for you.
Great.
And yeah, I've got a question for you. I'll type it in, but I'll just say it now whilst I'm typing. Can COVID-19, the corona disease, spread through raw food?
I think we have to say there's actually almost no published evidence. That doesn't mean to say it doesn't happen, that there's very little evidence that we can, thanks Vic, there's very little evidence that of catching COVID from hard surfaces on the whole, or from the environment. There will be some. So if I have COVID, cough into my hand and pass mark, I'm in New Zealand, but past Mark in England, a scone, then just because I've coughed 100,000 virus into that scone and he eats it, there's a good chance he's going to get COVID. But in fact, the COVID virus, unlike some other viruses, COVID like influenza virus, dies very rapidly in the environment. And the numbers come down really quite fast. They may live for 2 or 3 days, but at numbers that are far too small to cause an infection. So even after a few minutes to an hour or two, the numbers will be dropping dramatically and reducing the chances of infection. But we're a bit nervous about that with COVID, so we like to go the extra mile just in case.
Yeah, very. Well, yeah, thanks for explaining that. Yeah, because this is a bit, because most people, they wouldn't know. They'll be just thinking, oh, you know, because people are doing a guesswork in terms of COVID-19. So these simple questions will help out people out there to be careful.
They're really, really good questions, the simple ones. And we have to remember that COVID has only been amongst humans on this world since November, December last year. So we're learning really, really fast, and it pays to always have that precautionary principle, do a little bit more than we think is required for a start until we know how much it really makes a difference or not in a number of different aspects. Mark, thank you.
Yeah, I've got another. Yeah, I've got a set of questions.
Great, so, good. Keep the flag.
Well, yeah, just to keep the program going, because I knew that I'll be coming here live, so you have to have your questions ready. So I've written them down for you. So my second question for you will be: can the coronavirus disease spread through sewage?
Okay, for the same reason, it's interesting. Sewage is very good for detecting, or fairly good for detecting, is there COVID in that community or not? And similarly, sewage can be used for testing, is there drugs in that community, illicit, legal or illegal drugs, and which types are the most common, and all that sort of thing. Sewage can be good for that. The chances of catching COVID from sewage, I think, will be close to zero. Because for the reasons I've said, COVID virus, unlike the gastroenteritis, diarrhea and vomiting virus, the norovirus is very, very tough, and that lives for some weeks, and it's got a really low, what we call infectious dose. So for every 1 gram of feces of somebody with norovirus, there's 1,000 million viruses for every gram of feces. And we may defecate a kilogram a day or something like that, and there's 1,000 million. And so only small numbers, 10 to 20 is all we'd need to have from shellfish or something like that from sewage. I think COVID, good detection to tell if it's in the community, but almost zero chance of catching it from feces.
Thanks for explaining. We've got our guy Signoro. He's always coming in on this program. He's got a question for you. I raised a couple of questions a couple of weeks ago in what I believe is the center of controversy in the COVID-19 guidelines, but unfortunately I did not get any convincing responses.
If you just write what the questions are.
I thought it was a question, So it's a bit of a complaint, really, that he didn't get what he wanted. But I'll just say, I know he's watching. Unfortunately, we are here to answer, questions about COVID-19. The guidelines are not set by us. We are just an audience behind the scene. So the guidelines, Ben, I don't think you'll be in a position to challenge the guidelines because
I would. Yes, I would if it happens. The guidelines, it's a good point. The person that sent that, if you could re-ask some of your questions so we can ask them specifically. What's happened with the guidelines? I'll put it to you this way. If you were the Director General or whatever of health in Zimbabwe, and you held all the PPE, all the gowns and masks and gowns, masks, and visors, if you had 2 million of them, and of each of those gowns, masks, and you thought, how long, and the United States has bought up all the rest, so you cannot get new supplies. So you thought, wow, COVID may be in Africa for another 3 to 5 years. We know ideally everybody will be wearing N95 masks everywhere out on the streets, but we haven't got enough. So we're going to make the guidelines with that in mind. So we're not going to use them when they should be used necessarily. We're going to use them with a strong bias towards restraint and the most urgent cases only. Not when they should be used, but the most urgent cases only, not only for now, but for in 6 months' time, a year's time. Because if you marked with the head of were responsible for all the masks in Zimbabwe, and they ran out after 6 months because you did what you felt was best to using them all the time, you're going to be strung up for having none left in 6 months' time. So the guidelines themselves, they're correct, but only based on unfortunate circumstances of not having enough to go around. So there's a trade-off. So we can't say they're correct or incorrect, but somebody's made the judgment that with the resources we've got, this is what we're going to have to trim the guidelines back to.
Yeah, I think you've answered it very well. Yeah, it's like here in the United Kingdom, we had a situation whereby there were some nurses who came online complaining about not getting the right gear. They were saying we're only given a mask and we're not given the face shield, we're not given the overall, that suit you wear. They said, but they were saying they were working in the intensive care unit where the exposure is great. So they were saying they were not looked after, and they got there, some of their friends died of COVID-19 because they were not well protected. Like what you're saying, it depends.
And it's tragic. It's tragic, and they're quite right. They died because they didn't have the protect gear. There may be some behavioral parts in there too. In other words, not only having the correct gear, but we've got to use it properly. They've got to have the correct gear, but the tragedy is nobody in the world has enough of the correct gear.
That's very true. Because it's like for instance, I'll give my example in Zimbabwe. We've got this 20-second rule where you say you have to wash your hands for 20 seconds. If someone in the village doesn't have running water, how can they wash their hands for 20 seconds? Because the water they get is for them to drink. They can't spare water to wash their hands for 20 seconds. So it's like what you said. You explained it very well. It depends where you are and where the situation is. As
you raise that with sorry to interrupt. As you raise that with water, for instance, even the single most important way above everything else, I personally believe, of preventing the spread of COVID is when you're sharing the same air as other people. So that tends to be in a room or in a bus, public transport or something like that. When you're sharing the same air is by far the highest risk. So wearing a mask, even if it's homemade, is by far the most protective thing you can do. Much lower down is if you happen to have contaminated hands because you've touched another surface of somebody who's coughed into their hand and then pushed a PIN number or opened a door, you will never catch COVID from totally contaminated hands in itself. What I'm meaning is the COVID never goes through your skin. The only way it can get in is if you then eat something from your contaminated hands. And so if you do not touch your face, mouth, nose, so the mucosal surfaces, eyes, nose, mouth, with your contaminated hands, you'll not get COVID, even if they're swimming with COVID. But if you're not wearing a mask and you're breathing the same air as somebody with COVID, you'll increase the chances. And that COVID on hands will be probably neutralized. If you haven't used alcohol on your hands, it'll probably be neutralized. And I'm guessing, and I emphasize I'm guessing now, in 10 minutes to half an hour on your hands.
Well explained. You've explained it very well, Ben. That's why we want you on this program. So I've got another question for you, because I've seen on the comments there isn't any now, so I'll crack on with my questions.
Yep, great. Yes.
I've got a question for you. It goes on to say, is there a relationship between the coronavirus and medications for HIV?
I'd have to say no, none whatsoever. In simple terms, depending what you mean by correlation. If you've got, we had a similar question the other week. If a person has HIV, their immune system will be a little bit suppressed, because that's what happens with HIV. The medication will actually bring it up to almost normal, actually, the HIV medications. So I don't think there's any indication at all that it makes you more predisposed to COVID. There is, however, some indication, it won't be very much, but if somebody has a lower immunity because of HIV, unusually, they may be less likely to get serious COVID infection, because the better your immune system is, the higher the immune response to it. And in the case of COVID, more than most other infections, it's that heightened immune response with COVID that causes the main troubles. And so it's like having extraordinarily bad hay fever or an allergy when we have COVID. It really sets off. So if you've got a lower immune system, and dexamethasone, for instance, lowers the immune system a little bit, there's maybe a 10%, you may be 10% less likely to get really serious infection. So it's a little bit not what you'd normally expect. And I'd make the other comment that Africa has a relatively high proportion of people with HIV, and it has not swept through COVID, at least so far. And other than South Africa, and that may be for other reasons, having had more access to more medications, it has not swept through Africa's 1.2 billion people at all, unlike the United States. So it may well be that people are better protected in Africa than anywhere else in the world for other reasons. Mark?
Yeah, you've explained it very well. Yeah, it's like, these guidelines are I think they are they're there to protect us, but they don't imply in all countries, because in Africa, like what you said,
That's
so
right.
Signora is very into the program today. He just posted another comment. I think it's a comment. I'll just read it out to you.
Oh,
Absolutely, it's a mission impossible to apply some of these WHO guidelines. That's a perfect example about washing hands in Zimbabwe. The list is long. So there's an oversight in these policies. It doesn't work evenly across the globe. Yeah.
So that's right. And if I could add, because it was a really good issue you raised, Mark, with scarcity of water, and WHO guidelines would be lots and lots of washing. But having said that, there may be parts in Zimbabwe where there is plenty of water and other parts where there's not. So there can never be an all-encompassing guideline, because there can be quite small interregional variations. I just come back to the main thing is shared air is where it's mainly spread, and just keep it in perspective.
It's all about inhaling. Yeah, I get what you mean. Yeah, if you inhale through contaminated food or contaminated air, that's when you get it.
And if you think, just continuing from what I've said before, if you think you may have contaminated hands because you've been out in the village, and it's possible you won't know if you've got contaminated hands, then if you could not, or refrain from, if you can't wash your hands, just refrain from having finger food. So if you've got either a knife or fork or some other chopsticks, whatever you may use, then you will not be touching the food before eating it, and that would reduce the chances from foodborne.
Yeah. I told you I came here prepared today, Ben.
That's good. You're doing a good job. Thank you, Mark.
Yeah, I've got another question for you. Yeah, just to keep the show going, because I'm reading the comments, because I want to include the audience. But if they're not engaging, I have to keep the show going. So I have to read the questions. Yeah. I don't want to be selfish. If there are questions there, we'll read the questions first. But there isn't any. So I'll read mine now. So it says, how long does it take for someone with the COVID-19 to become infectious?
That's a good question. Generally, after they've had contact, most people, some things we don't know, they'll start showing symptoms after 5 to 7 days. So they'll show symptoms after 5 to 7 days, but they may be infectious for at least 1 to 2, possibly 3 days, and occasionally 4 days beforehand. Right. So some of that will depend how big a dose, how many virus they were infected by in the first place, and how fast it's growing within the person. So it can take 9 or 10 days until they get symptoms, but 2 and up to probably 4 days before you get symptoms, you may be infectious. And then there's a significant group of people, perhaps 20 to 60%, 20 to 60 out of every 100, who never develop symptoms after they've been infected, but then can spread it to others, even though they never develop symptoms.
Yeah, very true. Yeah.
Asymptomatic, it's called, without symptoms, asymptomatic. So that's tricky. So that's why you or I do not know if we're carrying COVID at the moment or not, and we could be infectious. So the shared air of anybody, especially in a closed space, can be a problem.
Very true. Very true. We've got another guest here, Doris Sibanda. She just joined us, I think, or she was watching. She's got she just put something on. She went on to say, am I not sure in case if you have no water with you, sanitizers, and you have been in contact on way home, is it safe to wash hands when you get home, or you have to stop somewhere to get home? I'm a bit confused.
No, that's a good question. Thanks, Doris. The simple answer is, and it's very hard to change habits, my simple advice is the risk will be 0 to you on your way home because the virus cannot penetrate through your skin. The risk will be 0 so long as you do not stop and pick up some sweets on the way and put them in your hand and put them in your mouth, or so long as you do not buy any food or accept any food from anyone and eat it on the way home. You can have totally contaminated hands walking home, so long as you do not touch your face or eat food, no trouble at all. You may wish to be a little bit careful if there's a door handle when you get home to get into your house, because if you touch that and someone else comes in and thinks they've got clean hands because they just washed them outside, then they can pick it up again on the door handle. So bearing those things in mind, if you've got water at home, no trouble at all. Go home, give them a wash at home, and so long as you haven't directly or indirectly touched your face, eyes, nose, mouth on the way home, no trouble at all. Thanks, Doris.
Yeah. Just on that issue, Ben, the sanitizers, let's say your hands are contaminated and then you happen to have a sanitizer. If you use the sanitizer on contaminated hands, will that kill the bacteria? What happens?
That's a good question. The alcohol sanitizer will kill the COVID very, very in a few seconds. And yes, it also kills your normal healthy bacteria on your hand. But over the next hour or two, your normal healthy bacteria will start regrowing on there again. It'll get contaminated from your other skin sites. So yes, it kills almost everything on your hands, including the COVID. Whereas if you were to use liquid soap and water, that kills COVID virus and influenza virus, as it happens, very, very easily. And you're still left with your normal, good, healthy bacteria on your hands. Now, there's a slightly interesting thing that happens. If you've used liquid soap and water, got rid of the COVID virus, but you have your normal, healthy bacteria on their hands, it's like germ warfare. If you subsequently get a little bit of COVID on your hands, COVID virus on your hands, your normal, healthy bugs are more efficient at killing that COVID virus than if you'd used alcohol, where there's no healthy bacteria there. So there's a bit of germ warfare going on.
Yeah, I'm learning every day. Yeah. Oh, she's back again, Doris.
That's great.
Oh, yeah. She says, also, when you get tested and you are negative, in the same week, you have been out in different cities. Can you test again?
Okay. So I'm going to give you two responses on that. If you test negative, unfortunately, that does not rule out COVID virus. The test does not detect all the COVID viruses. It may detect, if you've got 100 people that have COVID virus, maybe the test will only detect 80 out of that 100. So it will miss a number of them. That's the first point. A negative test never rules out COVID virus, or it may be too low numbers to detect at the moment. The second thing is, can you test again in the same week? That is one of these policy issues. And if there are enough tests available, and they've got plenty of tests, they may say, yes, if you've traveled, been to other cities and wish to retest again, that would be the ideal to do that. But if they can only have 1,000 tests a day in that region, they may say, no, we've used them up all. We've used them all up. So that's another examples where protocols are not necessarily ideal at all. But underlying, never believe a negative test. It does not rule out COVID virus. It helps and it's indicative, but it never rules it out. Mark.
Oh, well explained. Thank you, Ben. I think she's listening. She's seen you.
Right.
Yeah, you've explained it very well. Our main man, Vic Valentine, is back again. He went on to say, is it possible that we have several COVID virus now, such that some people may get 2 or 3 variants?
You ask good questions, Vic. I really like them. The virus is made up of a complex, vast number of genetic sequences, if you like, proteins. It's complex, there's tens of thousands of them. Now, they will always have tiny variations, tiny little mutations that do not materially affect the COVID infection at all. When there's a major change in those variations, then we have a whole new subtype, a whole new strain of COVID virus. That has not happened in any major way that's been detected anywhere in the world yet. So it's not like seasonal influenza that comes back quite differently often every year. The COVID virus seems to be mutating at about 1/6 of the rate of seasonal influenza. There will be tiny minor variations, and there may be some very slight differences in these variations in clinical outcomes. I don't think there's really enough studied on that yet, but those variations are really minor at the moment and nothing substantial. The bigger concern might be in 3 or 4 years' time, judged by influenza, and its slow mutation rate compared to influenza. It may be then that we have to worry more about a major change. But I think there have been some minor variations shown to have perhaps some minor clinical differences, but they're at the small end of the scale. Thanks, Mark, and thanks, Vic.
Yeah, thanks for explaining that, Ben. You're doing a great job here. I really appreciate that. Yeah, so yeah, we've got Signoro back again. These guys are competing today, aren't they? This is good. They're keeping the program going. We like it. Keep on going, guys. Yeah. He wanted to say, I'm a discordant partner, and there's only 1 in a million in this category. So I would like to know if this discordant characteristic also applies to COVID-19. Are such people immune to?
Okay, that's also a good question. In practice, for most pandemics, we would assume that on past experience with influenza, when a new strain comes through of a brand new influenza, so it's a pandemic and it's happened 3 times in the last century, then it infects about 2/3 of the population, and 1/3 do not seem to get it. Now, COVID has not been amongst humans for long enough yet to know, are there some genetic types that do not come down with it? But then within that, there may be some people that have caught it but do not have symptoms. So we don't know if they've technically had it or not. I would be very, very surprised, as in any population for any disease, even with HIV, there was absolutely nobody for a start, and then there's 2 or 3 people started to be found in the world who self-cured from HIV or just didn't seem to catch it. Rare in the case of HIV. I suspect, and it's only a guess, it may be higher with COVID. There may be a few more people that are immune to COVID than we realize, but we won't know maybe for another 5 years yet.
You're right. Yeah. I think he's listening. Yeah, because experiments are still going on, tests are still going on, so we don't have like concrete information about this. We'll explain then. Yeah, we've got a new guest. I think she was watching behind the scenes. She's got a question for you. She's called Sibongile. I know it's a bit
good
tongue-twisting name, Sibongile Sibanda. So yeah, she says, "Morning, Ben. What's this scientific explanation of why youngsters are less vulnerable to COVID than elders?"
Okay. Yeah. Thanks, Sibongile, is it? And I apologize for my poor pronunciation.
Okay.
No one knows for sure why they're less vulnerable. One possibility may be there's things called ACE2 receptors, capital A, capital C, capital E, 2 receptors that the COVID virus, and they're on us, on our respiratory cells. And we have them in the upper respiratory tract. These ACE2, as it's called, receptor cells, we have them in the lower respiratory tract, and we have some in the bowel. When we're young, and newborns and young, we have much fewer ACE2 receptors. As we get older, we get more of them. Now, I don't know for sure if that's the reason. There may be an immune reason. Part of our immune system just may be better when we're younger. But it may also be those ACE2 receptors, which we don't get more until we're older. And I think from memory, we get more still when we've got these pro-inflammatory conditions, which make us more vulnerable to COVID, which includes high blood pressure, obesity, pulmonary illness. We have more ACE2 receptors still. So thank you. It's a good question, but I think there's a lot to be learned on that yet as well. Mark.
Yeah. So we had a nice show, but I know we still got 5 minutes anyway. We can still
rapid fire questions. Rapid fire questions and answers.
When you say what you just said to me, just brought up something which happened to me recently. I'm a blood donor. Maybe you didn't know. I donate blood like twice a year. So when I went to donate my blood, they told me that because I'm an O plus, my blood type is O positive.
Yeah.
It said your blood type, it makes you more, like my immune is better. It's better. I can fight the COVID. If I get the COVID, 19, it fights it off because they were saying you got more white blood cells than the red. I think that's how they explained it. So it all comes back to the blood type, I think, as well, because they were saying most people who've got the A, B, and the A and the R, they are most vulnerable. They weren't able to fight the virus like the O blood type, if you get what I mean. So I was happy when they told me that. So yeah, so yeah.
So the danger is you know it, and you'll go out and you'll behave differently because you think you're more protected. As it happens, I thought, and I may well be wrong, for many illnesses, there is a correlation between blood group and your susceptibility to infection, and different bugs will have a different one. I thought it was, and I may definitely be wrong, I thought it was groups B, blood group B and AB that may have apparently been more protective, but I may be quite wrong.
Yeah.
Sibongile.
I think they were just trying to make me, more confident when I go out there. But they said, because they were saying my blood type can be used in any, like if someone needs blood, it's universal. That's what they told me. They said it can be used in any blood types because it can go in any. If a person who needs blood is an A, B, or R or whatever, if they get the O, it goes anywhere. It can fit anywhere. So I was like, oh, that's very good then, because I'll be helping out people, So yeah, I'm happy. Yeah. So yeah. So I think we had a good show. We still got about 3 minutes.
Is it?
Yeah.
Just lost that. We had the same blood group, and it's only may swing it, the blood group, say 10% or so. It's no more than that. It's wonderful you survived and are on the show. Thank you for that. You may wish to share your clinical experiences, your symptom experiences at some stage, but maybe not time today. Mark.
Yeah, so you should donate blood as well, Ben.
That's right.
Because it's good, in it? Because you're helping out people who are not well. So yeah, she's back, Casey. So I think we're
it's been a great show.
I'm positive as well, though.
I know. He's your regular one. He's one of your regular ones, Ben. He was here last week, and I think he had a few questions for you. She was here last week, and she had a few questions. But Lamile, next week, just bring your questions because Ben needs to be somewhere. And I just have to say something, Mark and Ben. You know what, Ben? You know how busy I am here. I managed to make dinner whilst you guys were talking, and Sadza and Borovosi, and the kids are eating now. So you see, this is the good thing about when someone takes over, even if it's just 1 hour of my time, it's amazing.
And my niece and my son, who arrived just at the beginning of the show, they said they'd hold off having dinner until I'd finished.
That's why I thought, let me round it off on time. So I was downstairs. I was just controlling it from my phone. So it's working out. So Mark, I just have to say thank you so much for doing this. And I think it's been a great show. I was listening and I was just following from downstairs. And Ben, thank you so much for joining us. To all the viewers.
Thanks, Mark.
No, you're welcome. Yeah, I'm always here. Yeah, I'm always here till eternity. I'm not going anyway. So yeah.
Ben, not Ben, Mark. Mark. People say the moment you hear Casey going like Mark. Mark.
That's
first warning, Mark. First warning.
Oh yeah. She's about to. Yeah, I know. Yeah, she's very, assertive.
I know. Believe me, I know.
Yeah, Ben, but you've survived how many years now? 3.
3
and
years,
you're still tolerating that. So you're okay. Mark will survive. He'll survive.
If you hear talking, you'll be thinking it's like a big woman. She's tiny, but she's got a big personality.
Word of advice: don't tell her she's a big woman.
Yeah, I know.
I think we better close this show before these guys start eating me. All right. But to everyone else, those if you've got questions that didn't get answered, we just really have to close the shows. And with all our other shows, guys, we're gonna be keeping them at 1.5 hours, nothing beyond that. And this is an hour show, unless if Ben wants to sort of like present something that's more than an hour, we'll be happy with that. But thank you so much for tuning in and for all your questions. Start writing down your questions now for next week. And just know that this is a set time for question and answer on COVID-19 infection control related issues with our medical microbiology and scientist, Ben Harris. And yeah, thank you for your time. Yeah.
So, word of warning, I may be in Auckland next Tuesday. So we can still organize it one way or the other, perhaps.
No, Ben, that's perfect. You know what? I'm going to invite you to my studio and we can do it together. Like, you know what I mean? Okay. No, that'll be perfect. Then what it means is, I mean, we don't have to worry about doing it like this. We might just go straight onto Facebook or whatever. But Mark will be here.
Yeah, I'll be here.
Is that right, Mark?
Yeah, I'll be here. I'm in this program till it ends. I don't know when it's ending.
It's not gonna end. It will end when Ben goes, because we all know Ben is going first.
Yeah.
But I'm only going to be here for 1,000 years, I'm afraid.
Cheeky Katina, she's cheeking it. You never know.
No, he's got his own recipe of making himself live longer than everybody else on this earth, apparently.
Well said. Yeah, that's the right way to say it. Yeah.
All right. It's been amazing. Thank you so much. Thank you, Ben. And say hello to your family. Nobody opened the door today, Ben. I'm trying to have a look. Let's see. Jane didn't come to pop in today.
So to all the viewers, it's been nice having you and supporting us. Keep on supporting us. We're here to learn and to make people, you know, they have to be aware of this COVID-19. So we're here to explain it further with our Ben, with our advocate Casey and Mark as well, helping out behind the scenes. So yeah, thank you for watching.
Thank you, Mark. You're awesome. All right, thank you guys. We'll catch up soon. And yes, I will be back tomorrow with feedback about the advocate page. Again, we're carrying on part 2 tonight again. So thank you so much. I'm just going to end the broadcast. You guys stay there.